Hi everyone, my name's Anna. I am a PGY1 clinical pharmacy resident, and we can go ahead and get started on the presentation today. I'm excited to present on opportunistic infections in COVID-19, specifically with focusing on COVID-19-associated pulmonary aspergillosis. I want to give a big shout out to my content expert, Brian Buss, for all of his help and feedback and discussion when going through this content. And then the code for today is CAPA 19, which you can text to the number below. And I have no conflicts of interest or disclosures for this presentation. So the learning objectives are displayed on the slide here. As a result of the presentation, I hope that you guys will all be able to identify a typical presentation of an Aspergillus infection, COVID-19 infections, but more specifically COVID-19 associated pulmonary aspergillosis, otherwise known as CAPA, which is what I will call it for a lot of the presentation. Next, I hope you can assess risk factors for CAPA and some of the outcomes described in the literature. And then hopefully you'll be able to apply CAPA diagnostic criteria. And lastly, I hope you can create an appropriate treatment plan for a patient with CAPA and understand some key differences between antifungal therapies. So that's a lot of words, but really simplified learning objectives for you guys. I hope you guys can understand what is CAPA, who's at risk of CAPA, how can we diagnose it, and how can we treat it. So let's jump into the first learning objective of identifying the typical presentation. So thinking about what is CAPA. So we're going to start with the patient case to help guide us through the presentation. Our patient, we'll call them patient XX. He's a 58-year-old man who presents to the emergency department with cough, fever, shortness of breath that's been going on for a couple days. His past medical history is significant for type 2 diabetes, hypertension, BPH, and insomnia. On chest x-ray, he had bilateral opacities and his O2 sat was 82%. His COVID PCR was positive, so he was admitted for COVID-19 associated respiratory failure. He was started on supplemental O2, dexamethasone, remdesivir, and was also started on empiric antibiotics for community-acquired pneumonia. So on hospital day 3, he started developing worsening hypoxia and was started on high-flow nasal cannula. Tocilizumab was administered with his CRP being above that 7.5 cutoff at 7.8. However, on hospital day 6, he continued to deteriorate from a respiratory standpoint and was urgently intubated and started on mechanical ventilation. So this patient likely sounds familiar to a lot of us given our work during the COVID pandemic. And the initial chief complaint of like fever, shortness of breath, cough, hypoxia is what we know as the typical presentation of COVID. And some patients unfortunately progress to that mechanical ventilation stage, leading to ICU admission. So this graph here on the right side shows the trend of ICU admission among hospitalized patients with COVID-19 since March of 2020. And there's 3 different lines just because it's from 3 different data sources tracking hospital data across the country. But you can see it kind of started a little bit higher and now is in that like 10, 15 to 20 range, but still a significant proportion of patients are admitted to the ICU. Over 65 million of cases of COVID have been identified in the US with over 800,000 deaths. And those numbers, unfortunately, do keep increasing, and those are up the 16th of this month. So kind of the main pillars that we see a lot of for COVID-19 therapy are listed here. So remdesivir being the first as the nucleotide analog RNA polymerase inhibitor for the for the COVID-19 virus. We usually do the 5-day course, and this is typically started when patients have new or increased oxygen requirements. However, we can consider starting remdesivir at presentation in those at higher risk of deterioration. And there's even some new research looking at like outpatient use of remdesivir too. The other kind of pillar of therapy is dexamethasone, which is the corticosteroid that we typically use for COVID therapy. And usually we give the 6 milligrams per day for 10 days. And this is when patients do have the newer increased oxygen requirements and usually not sooner. And then tocilizumab is kind of the last one I'll touch base on. This is the IL-6 inhibitor. We usually give at least 1 dose of 800 milligrams when in combination with the corticosteroid when patients meet these criteria below. So within the first 5 days of hospitalization, when the CRP is greater than or equal to 7.5, and if they have this like rapidly increasing oxygen need, despite being on other treatment, or if they're started on the high flow nasal cannula. Usually tocilizumab doesn't have the benefit when started after mechanical ventilation. So let's go back to our patient. So our patient on hospital day 12, you're rounding with the ICU team now, and you see the following micro results from the BAL that was collected 3 days after the patient's respiratory status worsened and his fever came back. So the BAL culture showed the preliminary results, and the BAL galactomannan was positive at 1.1. So what infection could this be representative of? And I won't look at the chat because this is kind of just a rhetorical question, because hopefully you paid attention to the title of the presentation, but also with the clues from the BAL, you may be thinking of Aspergillus. So let's touch base on Aspergillus just as an organism. So usually it's found in the environment, in soil, moist environments, or vegetation, and it's spread via inhalation of spores. So typically we see a pulmonary sort of manifestation of Aspergillus, but it can be, you may see it like in sinus infections or in like severe cases or cutaneous manifestations, ocular manifestations, but by far the pulmonary manifestation and presentation is most common. Some people who inhale Aspergillus don't clear it and may be colonized with it and just be asymptomatic, and some people it can lead to invasive disease. And usually the most common organism or species is the Aspergillus fumigatus complex, but others are out there but tend to be more resistant. And so how a patient presents can depend on the host's immune system. You can think the more immunosuppressed a patient is, typically they have a more invasive infection. So subjectively, it may be more nonspecific with the fever, cough, chest pain, shortness of breath. But objectively, there's some more findings that can be more specific to Aspergillus. So on imaging, on CT, you may see focal consolidations or nodules with the halos or what are the surrounding ground glass infiltrates. Also, cavitary lesions is kind of another like buzzword that you may lead you to think Aspergillus. And then aspergillomas are like a big fungus ball that are can be seen in immunocompromised patients. And then we can use a BAL to collect a culture for fungal species, and then also galactomannans in the serum or the BAL. So who is at risk of invasive pulmonary aspergillosis? It's not something that we see as common as something like pneumonia, just regular community-acquired pneumonia. So there's special patient populations who are at higher risk of invasive pulmonary aspergillosis. And this is just regular aspergillosis, not necessarily COVID-related. So the immunocompromised patient population is the biggest. So those with solid organ transplants or stem cell transplants, who are neutropenic or maybe immunosuppressed via medications. And then also patients who have lung injuries or that impaired mucociliary clearance. So those with structural lung disease like COPD or pulmonary fibrosis may be at higher risk, or even those with like recent acute lung injury, like from viral infections like influenza. So normally, our bodies have normal defense mechanisms in place to protect us against Aspergillus. And you can see here some things that impair these normal responses. And so you can think like, oh, it makes sense why those who are immunosuppressed or are taking immunosuppressive medications may be at higher risk of Aspergillus, because some of these things aren't impaired, or these normal mechanisms are impaired by certain medications. So first, starting at the top, kind of the most like basic defense mechanism that we have in place is mucociliary clearance, which, like I said, is impaired in structural lung disease, viral infections. And so other cellular responses like the formation of reactive oxygen species or the nuclear factor of activated T cells, these all can activate neutrophils to help attack the invading pathogen. And then IL-6 usually induces the transcription of a transcription factor called STAT3, which increases that T cell response. And then you can see here, normally we have LC3 associated phagocytosis, which simply put is just another clearance mechanism that we have that is impaired by corticosteroids. Oops. And then lastly, our T cell response, so our CD4 T cells and our CD8 response can be impaired by T cell immunosuppression or lymphopenia. So all of these things are normally in place for us, but there are some things that can happen outwardly that can impair these normal responses. So now it's a time for an audience question. What traditional risk factors for invasive pulmonary aspergillosis does our patient XX, have? A is type 1 diabetes, B is hypertension, and C is BPH, and D is lung injury or infection. Awesome, yeah, so everyone's getting it right, good job. So lung injury or infection is the traditional risk factor that our patient has, but you can see I reminded you on the right side here of the other typical risk factors. So immunocompromised status, and then even like structural lung disease, so that could be like COPD. So even though our patient does have the risk factor of the recent lung injury with the virus, with COVID-19 virus, is he really at risk for Aspergillus infection? And so to answer this, the next part of our presentation will focus on the risk factors for COVID-19-associated pulmonary aspergillosis as described in the literature. And then we'll also compare those to the typical invasive pulmonary aspergillus risk factors that we just talked about. So COVID-19 itself is a unique infection that can affect our immune system. So we'll kind of walk through some of the normal responses that our bodies have after infection with COVID. So COVID can cause increases in these pro-inflammatory cytokines or chemokines. So that includes TNF alpha or IL-6. And this can be like thought of as that cytokine storm that leads to increased neutrophil response, increased T cell response, and all of those kind of migrating to the lung tissue. So this response over time can lead to tissue necrosis and injury and acute respiratory distress syndrome, or ARDS. And then just as a reminder, normally IL-6 can be protective against Aspergillus and is usually elevated after infection to help with the transcription factor of STAT3 to help with the immune response. And so COVID-19 lastly can also cause lymphopenia over time, and so low T cells. So thinking back to that table too, which we'll revisit, low T cells is not always great for fighting off infection. And so the result of all of these things is that this impaired or altered immune defense can lead to a higher risk of infection. So let's go back to this slide and break it down even more. So first, COVID can, like we said, cause impairment of the mucociliary clearance by causing the ARDS and taking away that normal defense mechanism. And recall that tocilizumab is an IL-6 inhibitor. So if we do use tocilizumab in patients, this does impair one of the other normal defense mechanisms. And as discussed, dexamethasone is a key pillar to COVID therapy. So this also can decrease our normal immune response. And then, like I said on the previous slide, the lymphopenia can impair the other normal T cell response. So when looking at the pathophysiology about why COVID patients may be at higher risk of COVID-associated Aspergillus, we may already kind of start to form these hypotheses in our mind of risk factors that would be specific for CAPA, like IL-6 inhibitors or COVID therapies and things like that. But what does the literature say? And that's going to be kind of what we talk about next. So first we'll examine a study from Bartoletti, which is a study that took place in Italy. And I'll be referencing this study throughout the presentation, so pay close attention. So this study was a prospective multi-center study in Italy from February to April of 2020. And this looked specifically at intubated and mechanically ventilated critically ill COVID patients. They were excluded if they were discharged from the ICU after 48 hours, so just had like a short stay, or if they had to go to the ICU for other reasons. So this study used preemptive monitoring to look for fungal markers to monitor like how well certain diagnostic criteria were. So really what you need to know is that they did a BAL on ICU admission on day 0, on day 7, and then just kind of continued to monitor a BAL if there were any signs of clinical decline, which included like a worsening fever, worsening respiratory status, or like respiratory secretions increasing. And the BAL, they looked at cultures and galactomannan. So 108 patients were included in this study, and up to 27% of patients were diagnosed with COVID-associated aspergillosis. And usually the median time to diagnosis was 4 days from intubation and 14 days from symptom onset. Interestingly, the only factor that they found significantly associated with CAPA diagnosis was chronic steroid therapy. And so by chronic steroid therapy, they define this as equivalent to prednisone 16 milligrams per day for 15 or more days. So it's not quite the dose, I guess, that we would think about as immunosuppression at that 20 milligrams per day, but it is very close. So it's kind of difficult to assess that from like a immunosuppression standpoint. So of note then, other sources of immunosuppression like solid organ transplant or malignancy, they were measured, but they were similar between the group who was diagnosed with CAPA and those who weren't. And so these results are interesting because they also align with remdesivir and tocilizumab and acute use of corticosteroids, so like dexamethasone, the 6 milligrams that we typically think of. All of those were also not significantly associated with CAPA diagnosis. And so these results are interesting, but I also want to point out that this is a small sample size of only 108 patients. And the population of the immunosuppressed was only 8 solid organ transplants and 13 patients with malignancy. So there is a chance that we're missing some difference that does actually exist, so a type 2 error. So just acknowledging that, and then also acknowledging that therapy has changed a lot since 2020 for COVID-19. So only about 50% of patients in this study actually received like the short course of steroids for COVID therapy. So there might be a difference there that we're also not catching either due to the small population size. All right, another study was done by Pratt, and this was a multi-center, multinational study, a cohort study that looked at a much larger population. So this was almost 600 COVID patients admitted to the ICU for acute respiratory failure. And different from Bartoletti's findings, they found 3 different risk factors associated with CAPA diagnosis. And these were older age, invasive mechanical ventilation, and administration of tocilizumab. So still, administration of steroids was not associated with increased risk of CAPA diagnosis. So another question for you guys. What was not a risk factor for COVID-associated pulmonary aspergillosis that was demonstrated by either the Bartoletti study or the Pratt study? Tocilizumab, immunosuppression, invasive mechanical ventilation, or corticosteroids? Okay, so I'm seeing Cs, and actually, so the answer, so what is not a risk factor that was demonstrated? So actually, the ones that were demonstrated, oops, wrong. So Bartoletti found that chronic steroid use was associated with CAPA diagnosis, and Pratt found that age, or older age, invasive mechanical ventilation, and tocilizumab were also associated with CAPA diagnosis. So the answer here is actually B, kind of a trickier question, because neither found a significant difference in regards to immunosuppression status, so malignancy, solid organ transplant, which kind of goes against the normal, typical invasive pulmonary aspergillosis risk factors that we discussed earlier. So in summary, what can we take away as risk factors for CAPA? So literature suggests that the typical invasive fungal infection risk factors that we talked about, like immunosuppression, structural lung disease, are not risk factors that we've seen yet for COVID-associated pulmonary aspergillosis. But chronic corticosteroid use and mechanical ventilation, along with tocilizumab administration and older age, were risk factors for CAPA diagnosis. So again, just pointing out that chronic steroids is somewhat difficult to assess. This, the second one here, given the limitations of the small study sizes and the ability for them to potentially cause immunosuppression. So that still leaves us a question if steroids and how steroids increase the risk for CAPA. Okay, so now that we've discussed the typical presentation of aspergillosis infections and some risk factors for CAPA, let's start to think about how we could potentially diagnose a patient with CAPA. So when should we suspect that CAPA could be a potential cause for worsening respiratory symptoms in a patient who already has a respiratory infection? So the European Confederation of Medical Mycology, or this ECMM group, published a consensus statement with guidelines for when and how to diagnose patients with CAPA. And so they recommend that in critically ill patients with COVID-19 who have refractory respiratory failure for 5 to 14 days, despite receiving all of the recommended therapies, we should suspect CAPA as a potential cause for worsening respiratory failure if they have a fever that is refractory for more than 3 days, they have a new fever after being fever-free for more than 48 hours, if their respiratory status is worsening, if they have hemoptysis or new pleural friction rub or chest pain. And so once we have a suspicion for CAPA, kind of the next question is when should we consider testing or kind of screening these patients? And so the same organization recommends in patients who are PCR positive for COVID, we can screen them with a serum galactomannan and can consider doing that 3 times per week until they discharge from the ICU or they're fever-free for longer than 7 days and their lung function has improved. So this is a lot, 3 times per week, to do screening through serum galactomannans. And sometimes serum galactomannans aren't always the most specific for detecting aspergillosis. So this would be a lot, and this isn't done a lot in the ICUs, but it's just a consideration and something we can think about, especially if patients are worsening from a respiratory standpoint. And so the workup of CAPA is similar to that of regular invasive pulmonary aspergillosis. Kind of the main difference, though, is that imaging won't be as reliable in COVID patients than it would be in a patient without COVID. So we may more heavily rely on other factors for diagnosis and workup. So given CT imaging may not be as reliable, we may put more weight onto the lower respiratory tract cultures, the galactomannan biomarkers, and then also the clinical presentation. So really a big clue to suspect CAPA would be progressive respiratory decline. And so kind of touching base on imaging, so this here shown is a halo sign that's consistent with invasive pulmonary aspergillosis in a non-COVID patient. So it's a pretty telltale sign to suggest Aspergillus, but in COVID patients whose lungs are already very damaged, CT imaging may not be the most reliable source of detection of Aspergillus. So again, that leads us to thinking about other forms of diagnosis. So let's take a step back here and go back to traditional invasive pulmonary aspergillosis. So the European Organization for Research and Treatment of Cancer have this set of diagnostic criteria, and they have kind of different categories of pulmonary aspergillosis as proven, probable, or possible. Proven usually involves like a lung biopsy and direct tissue sample, which is very invasive and not done very often. So probable IPA is kind of what is more commonly used. And so there are three buckets that you can kind of think about for diagnosis of probable invasive pulmonary aspergillosis. And again, this is in non-COVID patients. So first is host factors, which align really closely with the immunosuppression risk factors that we discussed earlier. And then CT imaging. So again, the lesions with or without a halo sign, cavitary lesions, or like a wedge shape consolidation. Oops. And then lastly, the mycological evidence. So using the BAL cultures, the BAL galactomanins to help us think about Aspergillus as a diagnosis. So you can see that all of the host factors are centered around immunocompromised conditions, which isn't necessarily all of our COVID patients who may be at risk. So it's difficult to apply the EORTC criteria that I just showed to all COVID patients. And again, especially because the imaging is difficult given the ARDS picture from COVID respiratory failure. So what does that leave us then? So let's go back to our patient and think about how we could diagnose CAPA in patient XX. So again, looking at the EORTC diagnostic criteria, how does patient XX fit in here? So again, we established that he is not immunocompromised at baseline, so we can't really use any of the host factors. And then CT imaging is not easily relied on. So really the only criteria here that he would satisfy is the mycological evidence. And so sometimes also relying only on mycological evidence can be misleading because some patients are colonized with Aspergillus, if you remember. So it can be difficult to determine clinically significant disease and an infection versus colonization if we don't take into account the whole patient in their clinical picture. So since the EORTC criteria is designed for immunocompromised patients, let's look at some other diagnostic criteria that's been suggested. So going back to the Italy study with Bartoletti, they compared two different definitions for CAPA to see like how that affected diagnosis rates. And so first was the CAPA criteria, and this involves ICU patients with pulmonary infiltrates, and they just needed one of the following. So a serum galactomannan greater than 0.5, a BAL galactomannan greater than 1, or a positive BAL culture, or a cavitary infiltrate if they are able to see it on imaging. And this had a higher rate of diagnosis than the putative IPA criteria or PIPA. And PIPA requires all four of these things. So requires a positive lower respiratory culture, signs and symptoms, and compatible imaging. And then either they need to have like the normal immunocompromised risk factors, or branching hyphae and smear, or lack of bacterial growth. And so, again, PIPA relies on these lower respiratory cultures, where the CAPA criteria can use surrogate markers like galactomannan to make the diagnosis. So it does make sense, again, that there is a higher rate of diagnosis here. But in this study, both had higher rates of mortality. So really, either one could be used. So we just kind of need, most patients qualify based on imaging. and signs and symptoms. So really what we need is some sort of biomarker or a positive culture to make the diagnosis. And so highlighted in red is going back to our patient. So imaging, we'll assume for him that his imaging was compatible. And then his worsening respiratory failure qualifies the signs and symptoms here. And then his cultures also qualify him. So using both criteria, our patient would need the diagnosis for CAPA. So that was a lot all at once, going through the diagnosis. And it makes sense because it is challenging. So again, it is difficult to apply the normal traditional invasive pulmonary aspergillosis diagnostic criteria to COVID patients. The imaging is not as reliable given the ARDS caused by COVID, and then also the traditional criteria is targeted for immunocompromised patients, which may not always fit the COVID patient population. And so there are alternatives that can be more specific to CAPA, and those include the two that we just went through. And then the ECMM consensus document also has some proposed as well. And again, sometimes with COVID patients, given the precautions and isolation that those patients are under, sampling may be more limited, and there may be increased use of upper respiratory tract samples. And so we always just kind of have to be evaluating the question of, could the microbiology results be due to colonization versus infection? And then lastly, I think probably the biggest thing is that we have to look at the patient clinically to determine if CAPA could be a potential diagnosis. And so looking at them clinically can also help us assess, is this culture result or galactomannan result a result of colonization, or is this a result of worsening clinical status and potential invasive infection? All right, so now that we've diagnosed CAPA, how do we go about treating it? So this is a list of potential agents, and then I highlighted just a few key differences between them that a lot of you are probably very familiar with, but really the main takeaways are drug interactions with all of the azoles, and then pointing out that QTC prolongation is also of concern, except for Isavuconazole is the one that causes QTC shortening. And then Amphotericin B used to kind of be the go-to for Aspergillus, but due to nephrotoxicity and other toxicities with electrolytes, we often go with the azoles before. So now we will talk through some differences, or some comparisons rather, between the antifungal agents. So one study looked at Voriconazole versus Amphotericin B, and this was a non-inferiority trial. And the population was specifically immunocompromised patients with definite or probable invasive aspergillosis. They were excluded if they had any sort of renal dysfunction or hepatic dysfunction, or if they were needed any sort of additional respiratory support through ventilation. So, Vori versus Amphotericin with traditional dosing. Looking at the primary outcome of the non-inferiority as the primary outcome based on successful outcome at week 12 of therapy. And successful outcome is like a very vague outcome, but really it was determined by the study group based on radiological improvement and clinical status improvement, so reviewed by a board of reviewers. And so secondary outcomes that they looked at was superiority, safety, and survival. So looking at the outcome of successful outcomes, Voriconazole actually was both non-inferior and superior. And then also with survival, Voriconazole had better outcomes. So in conclusion, when comparing Voriconazole and Amphotericin B, it is non-inferior and actually superior for the treatment of Aspergillus infections as compared to Amphotericin B. So oftentimes we see Voriconazole as one of the first-line options. The next comparison we'll make is Voriconazole versus Isavuconazole, which is demonstrated through the SECURE trial. And kind of a similar design, this was a phase 3 non-inferiority trial that looked at patients who had proven, probable, or possible mold infections, and usually this was Aspergillus infections. And again, kind of similar to the previous study, they were excluded if they had any hepatic or renal dysfunction. And so giving Isavuconazole on a traditional dosing scheme of a loading dose followed by the maintenance dose, and then similarly for Voriconazole. And the primary outcome for this study was all-cause mortality from the first dose to day 42. And so looking at 10% as that top margin for the non-inferiority margin, when comparing Isavuconazole and Voriconazole, the difference was non-significant, I guess, or non-inferior rather, for Isavu versus Voriconazole. Isavuconazole also had less adverse effects, specifically related to the visual disturbances that are associated with Voriconazole, and like hepatobiliary disorders or skin and soft tissue disorders. So in conclusion, for the SECURE trial, Voriconazole, or Isavuconazole, excuse me, is non-inferior for the treatment of Aspergillus infections as compared to Voriconazole. And then the last comparison between the antifungals is Voriconazole versus Posaconazole. And very similar design, another non-inferiority trial in patients with proven, probable, or possible Aspergillus. And same exclusion criteria, but with a little bit different renal cutoffs. And then they also excluded patients who had already been treated for Aspergillus, who failed, or if it was chronic or recurrent Aspergillus. So again, the Posaconazole had the IV or PO loading dose, followed by the maintenance dose, and similar with Voriconazole. And they were treated for longer than the 42 days, through 84 days. And again, they looked at all-cause mortality to day 42, similar to the Vori versus Isavu study. Similar non-inferiority margin of 10%, and so that allows us to draw the conclusion that Posaconazole was non-inferior to Voriconazole when looking at all-cause mortality. And again, Posaconazole also had less adverse effects as compared to Voriconazole. So very similar conclusion. Posaconazole is non-inferior for the treatment of Aspergillus infections as compared to Voriconazole. And so when we're evaluating the differences between these three agents, we can kind of think of, I guess, a lot of considerations. So hospital formulary, of course, is one, but then also what's the patient's status, like do they have a feeding tube? What is their renal function like? Are they able to take oral medications? And then what side effects are they specifically at risk for? QTC prolongation? Do they have they had visual disturbances with Voriconazole? So there's lots of considerations. Also, what is covered by their insurance, because they will be on a prolonged course of treatment. So after all of this discussion of the types of antifungals, I think the bigger question is, do they work for the treatment of CAPA? And really what's out there in the literature suggests that it doesn't really make a difference. So going back to the Bartoletti study, so of the patients with CAPA diagnosis, about half of them received antifungal therapy, but there was no significant difference between the two groups in terms of mortality. So you can see here on the right, this is that Kaplan-Meier curve for survival. So Voriconazole is the red line on top that, at first glance may make you think it could be superior, but really there was no clinically statistically significant difference between the groups. Mortality was higher in CAPA patients overall as compared to those without CAPA, but in regards to those who got antifungal treatment, it really didn't make a difference. And then another study based in France from Bertin also looked at a lot of different fungal infections in COVID ICU patients. But specifically, they looked at 154 cases of COVID-associated pulmonary aspergillosis. And they had a little bit longer time to diagnosis of CAPA than the Bartoletti study, but they also reported a very high mortality rate. So their mortality rate of CAPA was 46.1%, and they reported a COVID mortality rate in patients without fungal co-infections at 22.6%. So obviously, CAPA is not a great marker of outlook for these patients. And similarly to Bartoletti's results, this study found no difference in mortality between those who didn't receive antifungals and those who did. So you can see below, not significant statistically. So what does contribute to mortality in these patients? Obviously, like the CAPA has, or the pulmonary aspergillosis is causing this respiratory decline, but are there patients who are at higher risk of mortality versus other groups? And so this study based in France did look at CAPA patients and kind of broke them into three groups. So the first group was those who were immunosuppressed. The second were those with a history of underlying pulmonary disease. And then the last group was were those with no immunosuppression or underlying respiratory disease. And you can see the numbers here. Those who were immunosuppressed had the highest rates of mortality, followed by those with a history of respiratory disease, followed by those with no immunosuppression or underlying respiratory disease. So it's all a little bit confusing because the patients who meet the typical risk factors for invasive pulmonary aspergillosis, so immunosuppressed, history of respiratory disease, these are the patients who are at a higher risk of mortality from COVID-associated pulmonary aspergillosis, but they aren't associated with a higher rates of diagnosis. So it's all a lot that we don't know, but it's important to keep in mind that these patients are at higher risk of decline after being diagnosed with CAPA. So given the high mortality associated with COVID-associated pulmonary aspergillosis, especially among certain populations, should we start antifungal therapy sooner? Or should we even use prophylaxis in these ICU patients? And so one study conducted by Hatzel and his team looked at this. So they did an observational study of ICU COVID patients with acute respiratory failure from September 2020 to May 2021. And they compared patients who received antifungal prophylaxis versus those without. And the primary agent used for prophylaxis was Posaconazole. So the primary outcome they had was CAPA incidence, and the secondary outcome they had was death. And about almost 60% of their 132 patients received antifungal prophylaxis. And again, most of that prophylaxis was with Posaconazole. So for the primary outcome of CAPA incidence at 30 days, CAPA incidence was lower in the prophylaxis group, significantly. However, the secondary outcome of 30-day mortality had no difference between prophylaxis versus no prophylaxis. And they even looked at this again at 90 days to see if there was a difference later on, and there was still no difference at 90 days. So this is also very perplexing because we know that CAPA has a really high mortality rate compared to patients without CAPA. So why are these patients who are at higher risk of having or be diagnosed with CAPA not having a significantly higher mortality rate? And so I think that leads us to the question, if we were prophylaxing against true clinically significant infection, or if we were just prophylaxing against detecting like colonization. And so this study, I think, leaves us with something interesting to think about, but I think more research is needed to determine if this is really clinically significant or not. So again, while it was associated with decreased incidence, there's no impact on mortality, which still leads to the question of, is this clinically useful? So this leads to my conclusions for my presentation. thank you all for sticking with me through it all. I know it's a lot to go through for something that we don't know that much about really, but we'll draw some conclusions based on what we discussed for the last 45 minutes or so. So first, COVID-19's disease pathophysiology in general and the treatment options that we have for it can put critically ill patients at a higher risk of opportunistic infections like COVID-associated pulmonary aspergillosis. But this can be difficult to diagnose in these patients because of difficulties with imaging, having to rely more heavily on cultures and biomarkers like galactomannan, and risk factors may not be as easily identifiable or reliable as like typical invasive pulmonary aspergillosis. As far as risk factors go, the ones that we've found suggested in the literature so far include corticosteroids, again, chronically used, tocilizumab, older age, and mechanical ventilation. And then patients with CAPA, we know, have a high mortality rate. And so this appears to be a marker of disease severity for these patients. And then lastly, antifungal options for treatment of CAPA include those azole antifungals and even amphotericin as another option. However, antifungal therapy may not lead to improved mortality, and prophylaxis needs more evidence to support its use in the ICU population. These are my references, and I'm happy to answer any questions, but thanks again for listening, and to Brian again for his help with the presentation, and don't forget to claim your CE. Oh, Julia asked, per this ECMM guideline, should we be getting galactomannans in our COVID ICU patients? Since most of them. Yeah, so I can try to go back to that slide. So Julia's question was, in patients who are in the ICU with COVID, regarding the screening criteria proposed by the consensus guidelines, if we should be screening them 3 times a week, since they are getting such high doses of steroids. And so as a reminder, here we go. So in patients who are COVID positive, we can consider 3 times a week. And so I think it's kind of more of a clinical decision on when to screen, because like we said, with the prophylaxis too, if we do get a positive galactomannan, it may be difficult to know exactly what to do with that result, whether to start antifungal prophylaxis or to treat, or if we do just wait for them to clinically decline. I think this is like guidance that is, I don't know, it's not super clear as to what to do with the result of the screening. So I think you have to associate it with how they're doing clinically. I don't know if Brian, you have anything else to add?
I kind of want to piggyback on what you said, but in the form of a question.
Okay.
So after looking at all this data on CAPA diagnosis and outcomes and the effect of prophylaxing being effective but not affecting mortality, what is the clinical utility to you for a CAPA diagnosis?
I think it's more of a marker of disease severity than really like helping us direct treatment in a way. I think most often cases we will start treatment, but I think it's a even bigger marker of how the patient will proceed clinically. I guess that makes sense.
I tend to agree with you. I think the guidelines are being overly, they recognize that there's a 25% risk of developing CAPA in these patients, and so they're recommending aggressive screening. However, treatment has absolutely no effect on outcome for these patients if they're positive. And even if you prophylax and prevent, like Aspergillus, it has no effect on outcome. So likely that Aspergillus might just be a red herring and that patient was dying from COVID anyway.
Sure.
So they're recommending aggressive screening, but that doesn't necessarily mean that we should screen that aggressively unless we have a clear utility for the screening or a higher clinical suspicion based on your risk factors.
Okay, Julia said also galactomannan is a send out, and I'm thinking about the headache of keeping track of all those. Yeah, so here it takes like 1 to 2 days, I think, until by the time it gets to the facility to report. So it's a send out, and after it arrives there, 1 to 2 days. So agreed, it would be kind of a headache to keep track of. Sarv asked, what's the specificity of the galactomannan test? So I don't know the exact like number, I guess, but it is more specific to Aspergillus as compared to like the beta-D-glucan. So that's why we wouldn't necessarily get the beta-D-glucan. We would rather have the galactomannan for Aspergillus. I don't know if you have anything to add.
You can have false positives. It's usually just based on the galactomannan level. So if you have a non-significant level, a level less than 0.5 or 0.7, it's deemed a false positive or not positive.
Sure. And yeah, so like the index cutoffs that some of the criteria had, like 0.5 and 1, so 0.5 for serum and would be more indicative of like more disseminated infection, and then BAL had a cutoff of 1 for the index. So yeah. Any other questions? Oh, Christine said, is there any data looking at CAPA outcomes in non-critically ill patients, like those on high flow nasopharyngeal but not intubated? I didn't come across any data. Like all of the studies were in mechanically ventilated ICU patients, which also makes sense like why it was identified as a risk factor in one of the studies. So yeah, unfortunately, I didn't see anything in those not intubated patients. Julia said, are there any other medications or conditions that can cause a false positive galactomannan like beta-glucans have? I think I did see something about like Zosyn potentially, but I don't know if that might be more beta-glucan like associated. So I'm not aware of them off the top of my head. Anyone else? All right, you can always email me or find me if you have any other questions, but thanks everyone for listening and for your involvement.